So, activities of daily living, ADLs. There are some things to do, so have a look at your modules. The things that we're going to get out of this lecture is the Roper-Logan-Tierney ADL model is really what the whole lecture is based around. So if you don't get anything from today, the next slide with a picture is really the one that it would be good to have front of your mind. And hopefully we'll be able to discuss what these different things mean to our patients. When I'm discussing these things, try and picture how this is going to be useful for you on your very first placement. So there you go. If you don't remember anything, this is the one slide that would be good because this kind of has everything. Now, as you can see over here, these, okay, that's not working, good. The factors over here, so the 5 factors, so biological, physiological, sociocultural, according to this model, those 5 worldly factors are factors that influence everything within our lives. And by that, these impact on the middle activities of daily living, and there's 12 of them. Now, to be healthy, we need to be able to, in some form or another, be able to have some dependence or independence for those 12 things to be able to have a fully healthy life. Now, the reason I'm stressing that, because back in the day, when I was a student, it was really to be healthy, you just had to be physically healthy. That was it. There was no one was interested in anything else. But here we can see, and that's ironic because this was developed in the 80s, and I'm not that old that I went to uni in the 70s. No one agreed? Thanks. So you can see here that physical health is just one thing, but things such as expressing sexuality, dying, sleeping, I mean, okay, breathing is probably important there, but there's lots of different facets of us being a healthy individual. Next to that, we have a dependence-independence continuum, because it's important also to remember, okay, I've got 5 worldly things, they impact my life. They impact these 12 things that cause me to be a healthy human, but it doesn't mean I have to be fully independent to be healthy. So an example of that is, my wife is also a nurse, and when we met, she used to work in a spinal unit in Sydney. Now, a lot of their patients, because of where their fracture is, are on continuous ventilation. So clearly when it comes to breathing, they are not going to be independent because they have a ventilator attached to them 24/7. But that doesn't mean that they are unhealthy. It just means that one factor of their life, they are dependent on something. So when we're looking at a healthy individual, it doesn't mean that they have to be fully independent. Now, the reason I say this is because, and this goes for everything within this course, you need to understand your worldview on everything you do to make sure that that doesn't affect someone that you look after. So it could be, for you youngsters who look very lovely and healthy and are possibly completely independent of all of them, it would be really easy to say, well, that's me. I'm healthy because I'm independent. That means that is what a healthy individual is. Because when you go into that aged care facility, there's going to be people very, very different from you. That doesn't mean they're any less healthy. That doesn't mean they're any less worthy of nursing care, but they're going to be very, very different. So you need to think about, okay, well, who am I as a person? What am I really independent on? What do I need assistance with? How does that shape me as a person? And make sure that that doesn't affect your nursing care. And I'm going to be mentioning that a lot during lectures, because a lot of the things that we're going to be covering here are things that you can have impact directly to your patients. And it's important that you know who you are so you don't impact them. So as I said, it was developed in the 80s, and there's 12 concepts that we've had a look at, and we'll look at them in a little bit more detail. The main thing here is that very first point, that dot point. The person develops and matures across the lifespan. So if we think about just a newborn baby developing to adolescence, they are completely dependent when they're born, and slowly through lots of different ways they gain independence. It could unfortunately be that when you in the aged care facility, that your patients are regressing from full independence back to dependence. Now, again, like I said, that doesn't mean that they're any less healthy. It just means that they're in a phase of their life where things are changing for them. The most important thing here is that just because we know that that might be a normal human kind of reaction to the world, that when I get old, I'm going to start kind of losing things and I'm going to need help. that doesn't mean that you're going to be comfortable with that. Now, I'm a bit follically challenged, but for a long, long time, I convinced myself I wasn't, until I caught a photo of myself from the back and realized that there was kind of like a big spot right there that had nothing. And I thought, maybe it's time to shave my head. Now, I should have known that getting old, things are going to happen. But that really affected me, and I didn't like it, and it took me a long time to come to terms with it. And what I'm trying to say is when you're looking at these 12 things and you're finding that people in your aged care facility are going to be dependent on you, you need to make sure that you're delivering that care, not just because you're a nurse, I'll do that for you, because for that person, that might be really traumatic that you're having to do that. So just think when you have to do your very first shower and you have to look after a man with these very long testicles, and you think, oh my God, I'm going to have to touch an old man, it's probably equally as embarrassing for him to be washed by a 20-something. So these are the 12 activities, and we're going to be covering these in a little bit more detail. I'm not going to be covering them in great detail because some of them I'm assuming you've already covered before. So communicating, I am assuming you have done a communication course. Some of the things like breathing, we're going to be having a lecture on respiration, so we're not obviously going to cover that in detail. But this is the reason that you don't have pre-readings, because you would have to have 12 different things. So we're only going to be touching on these very briefly, but if you obviously want to get a little bit more understanding, then you would have to look at these individually. So maintaining a safe environment, I'm not going to bang on about this because when I was listening to Peter Ann, I think she mentioned a lot about maintaining a safe environment, such as sanitation, pollution control. Now, this is probably one thing that when I was a student, I used to always think that when the senior nurses, and back in my day, that was the matron, they would be always saying, well, if you've got nothing to do, you can clean. And when I was a young student, I was like, I'm not a cleaner, I'm a nurse, I'm getting a degree, I'm not cleaning stuff. But as hopefully you understood from Peter Ann, that cleaning is actually quite a fundamental part of your role, because without cleaning and without a safe environment, we can't really add on care to our patients. Because if I think about my 10-year-old at home and I say, can you go and clean your room? And he's like, oh yeah, it's cleaned, but I have to step over lots of washing to get into his room. I'm like, I'm not really sure this is my ideal of clean. So we can't look after people in an unhealthy environment. If you have to walk over equipment, then just imagine your patient with dementia who's had a stroke trying to get out of bed and go to the toilet. This also includes medication error. So we're going to be looking at medications within your labs, and we'll be touching on that in lectures as well. I say that because I don't know any nurse who hasn't made a medication error. And it would be my desire for you guys never to ever make one. Now, my medication error, because I work in peds, was with a baby in resus with morphine. Probably not exactly the medication that you want to get wrong with a newborn of 6 weeks, but we gave 10 times the amount of morphine. And believe me, it's not a feeling that I would want anyone else to go through. So when we're going through these, and like I said, you could easily be sat in the room and going, yeah, okay, you've done that slide, let's get on. But try and think about how that's going to impact you. When you're going through your medication for the very first time in placement, make sure you take the time. Just try and think, well, if that was my mum, what would I want someone to do to make sure that they're not going to overdose her? Or underdose her, so she's going to be lying in the bed in pain. So make sure that you're thinking about these things, not just from the patient's point of view, but how can you make sure that you are assisting them in every factor of their activities of daily living. So, developmental age factors. So we've already mentioned when it comes to maintaining a safe environment, if we have a baby, they clearly can't maintain a safe environment. What's in hospital is a real issue with babies in hospitals and maintaining a safe environment. From my experience, the biggest issue, and remember we're looking at maintaining a safe environment, it kind of relates to lots of different people. When people come in, and this can be related to peds, it can be related to different families, the family think, well, I'm not going to do anything because this isn't my home, this is yours as a nurse, so I'm not going to do anything. And the real little things they forget to do. But as a nurse, you think, that's okay, mum's there, she's going to do it. The amount of times that we've had babies left in a cot with the side down while mum's gone out to have a cigarette because the mum said, oh, I didn't know I was allowed to put the rails up on the bed. But obviously as a nurse you think, well, isn't that common sense? You've left your baby in a bed, you're going to put the sides up. So remember that when it comes to you as a nurse, simple things like patient education are really important as well. Another developmental age factor, especially in the aged care facility, a lot of your patients might have Alzheimer's, delirium, and a lot of people put them in the bed and they put the sides up because they think, oh, that kind of keeps them in, they're not going to roll out of bed. The issue being is that when they go to the toilet, they try and climb over the rails to get out of bed. So sometimes you've got to make that kind of, that risk assessment. Is it better for the patient that I leave the rails down? So if they do go to the toilet, they don't have this extra hurdle of trying to climb over something to go to the toilet, or is it safer for them to have them up? I'm not going to go through everything else. So nursing actions, we mentioned some of them. So looking at what's around, making sure hazards are removed, that you're not having slips and trips, you're putting up signs if you need to, removing clutter. One down here, using systematic clinical handover. I also understand that you've learned this over at the college. So ISA-bar or S-bar, or there's lots of different ones. That doesn't seem, on the surface, something that is going to help you create a safe environment. But your S-bar or your ISA-bar, whatever you're going to use in the hospital, is actually really, really important because you're handing over quite vital things from one nurse to another nurse. If you miss things, it might mean that your patient may miss medications or they might miss an appointment. My example of this one is that I was handed over in the morning, the night staff clearly wanted to go home, and I was told, oh, they've been in for this procedure, I can't remember what it was, just have a look in the notes. They just need some neurovascular checks later on. Now, when I went and checked this patient's neurovascular obs, I squeezed the toe and said, oh, can you feel that? No. Oh, okay. So I got a little needle and I poked the toe and said, can you feel that? No. So I've immediately freaked out. I've called a met call. I pressed the buzzer's going off. The whole team has come to find out that what wasn't handed over to me was the patient had spina bifida and couldn't feel anything from her waist down. Why the patient didn't tell me that, she obviously thought it was hilarious that, yeah, I'm never going to feel that. Now, whilst that wasn't a safety issue, because, thankfully I did the right thing, just missing something really small because we want to go home can have quite big ramifications. The ramification for me was I got hauled into the matron's office and told, how dare you make that big mistake and cause all these important doctors to come to the ward. Thankfully, that doesn't happen anymore. If you're ever worried about your patient, make a met call, press the button. Safety education, so it says safety education for staff, but like I said, safety education for your patients is very important as well. So communication, who thinks they're a good communicator? I really found this difficult because we're not talking about your ability to communicate with your friend or your ability to communicate on Facebook. This is communicating with people who you may have never ever come into contact with. Who has sat down ever and had a conversation with an 80-year-old that doesn't really fully remember everything? That's quite a lot of you. Clearly you're all looking for vulnerable people on the bus. So for those that haven't, this is going to be quite challenging because I never knew how to talk to someone like that. I didn't know what kind of questions I was going to ask. I didn't know what I was going to do in that situation, and I found it really, really uncomfortable. This, unfortunately, is something that you're never going to be fully comfortable with until you're immersed in that. I can't teach anyone to be good therapeutic communicators until you've experienced some time on the ward. What I would say, however, is when you're on the ward or within your facility or wherever you're going to go, have a look at your nurses, because you'll find that most nurses have a bag full of responses. And they're responses that provide the patient with some comfort that you were listening, but don't really actually, mean anything. Now that sounds a bit cruel, but sometimes you need those kind of things, because if someone says something really awkward in the moment and you think, I really don't know how to answer that, there's nothing worse than standing there and thinking, I need to say something. I should probably say something now. This may be the longest time I've gone without saying anything. So it's good to have those kind of pocket of verbal responses that you can quickly throw out there. I'm very English, so my tip would be, go and make a cup of tea. Because if anyone says anything to you and you think, I do not know what to say, I can't really answer that at the moment, I'm going to go and get you a cup of tea. Now, what that does is that gives you 5 minutes and think, how am I going to answer that? And it also gives you 5 minutes to go and ask someone saying, oh my God, someone just asked me to wash their genitals and I don't know what to say. Is that normal for them or are they hitting on me? So it gives you, I mean, hopefully not that that's going to happen to anyone, but give yourself some time and think how, because there's nothing worse than, like me, just talking and trying to think you're funny and then you realise, oh, that didn't go down very well. But there's also nothing worse than just saying nothing. Therapeutic communication, I think that's on the next one. Now, this is very, very different from your normal interaction because therapeutic communication has a point to it. There is a stage where you need to engage in therapeutic communication, and there's also a stage where you end the therapeutic communication. Why or how do we think that we can engage in therapeutic communication? What is it about that that is different from social communication? How am I going to take my social communication and put it in a nursing context? We show people empathy. How do we show people empathy? What does that mean? Being empathetic, we're trying to put ourselves in the person's shoes. What don't we want to do? Similar to empathy, but people get confused. We don't want to sympathize. Why don't we want to sympathize with people? Because it's very easy for us to be really paternalistic and talk down to people. Oh, I'm going to pat you on the head, that must be awful. That doesn't provide anyone with anything, and if that was you, you'd probably feel like, did they really just say that to me? It's really, really difficult as well. Never say, oh, I know how you must feel. Now, if you're ever going to say that to anyone, you want to make sure that you can back it up with something. If someone has come in, their child has broken their legs, they're visibly upset, the parents are just going out of their mind, I can see how you feel. Really? So your child has broken their leg recently and you've been in bits. Now you can point things out and say, I can see you're upset. Is there anything I can do? Don't ever, ever say that kind of, and we do that, I think, with our friends all the time. Oh, yeah, oh, I understand, yeah. Oh, completely, yeah, totes, yeah. It's really easy to just say to our friends, just because, you know, they're our friends, oh, yeah, definitely, yeah. If I was like that, I would do that as well. But to our patients, that can be really, really upsetting, especially if you've had, but bearing in mind, when you're in a hospital, you might have only just got that patient to your bed, but they might have been in the GP for 4 hours, they might have gone to ED for 5 hours, they've been transferred to ward, and they're really not in the best mood. So the little thing that you do is going to tip them over the edge. So as you as a nurse, try not to tip them over the edge. Other things with this as well. Now, I found myself doing this to my wife. The one thing I found, so as well as the words we're using, as well as the tone that we're using. Now, I said to my wife, I was really cranky with her the other day, and she came up to me and said, so are you going to tell me? Are you going to tell me what I've said? What did I say that was so bad? And the words that came out of my mouth, which then made me laugh, well, it's not what you said, it's just how you said it. And as soon as I said it, I was like, that's so ridiculous. But remember, how you present yourself to your patients can have a really big impact. If you're having a really crappy day and you go in, so do you want a cup of tea? No, I'm fine, it's good, thanks. Just because you're having a crappy day doesn't mean that you should inflict that to your patients. And you might have the best will in the world to try and assist that patient during the day, but if you deliver that communication poorly, that might kind of, they're not going to talk to you for the rest of the day. Oh, I'm not saying anything, he's really cranky, I don't like him. And all of a sudden they miss their cares for the day. So try and check yourself when you walk through the door and find out, well, how am I feeling? Is that going to impact on my patient? Touch. When I was at uni, we were always told, now don't worry, I'm not going to do it to anyone, but we were always told that if it's something really kind of emotive, that the parent is really upset, you sit next to them. You don't sit like this, you sit kind of like, you know, in a triangle, so you're close enough, but you're not threatening by looking at them. You lean across and it was really prescriptive, like almost that you could tick a box. and you lean across and you put your hand on their shoulder, but you only leave it there for a couple of seconds, and then you come back and then you talk, and then maybe you put the hand on the shoulder. The very first time that that ever happened to me on the ward, a mother had had her baby in gallows traction. Now, I'm assuming everybody knows what traction is. So it's when you've probably seen in the old movies that someone's got their leg in plaster and there's weights hanging off the end of the bed because you're trying to pull the bone back in alignment. Gallows traction is when you try and do that with a baby. Funnily enough, babies don't like to lie still. So gallows traction is you put both their legs, even the healthy one, and you hang them up by their legs. That sounds a little crueler than it is. They're still lying on their back, but you're holding the legs. But every hour you would have to go in and unwind this baby because he would like ravel round and round, so he would literally be dangling by his legs. The mother had been in there for 5 days. The surgery had been cancelled 4 times. It was then cancelled for the 5th time and the mum lost it. And I completely agree with her. And I said, it's fine, I know what to do. So I walked in and I said, Mum, come and have a seat with me. No. Oh. I don't know what to do. And I literally stood there going, while she was shouting at me, because I didn't know what to do, I was like, but you sit down and I put my hand on you. So whilst sometimes we learn about prescriptive rules, sometimes they're not always going to be the thing that we can do. Culturally appropriate. There's been times when I've gone in and I've said to the child, when I came to Australia, you guys use, oh, don't be a pork chop, all the time, or at least you did in my ward. And I love that phrase. And I used to use it all the time until I said it to a boy without even thinking, look, I'm just taking your Band-Aid off, stop being a pork chop. Now that was fine. What I didn't really think of is the family were Muslim, and that was a little bit taboo, and I was like, oh my God. So what I'm saying is don't be like me. Try and find out the people, try and find your audience before you're communicating with people. However, I'm just going to point out, firstly, if it makes anyone more comfortable, I'm not practicing at the moment. So if anyone is worried and wants to report me to APRA, I just teach at the moment. All the stories where I'm really bad, it was when I was a student. I have progressed somewhat. So breathing on oxygen. This is quite an obvious one. Out of probably all of the 12 ADLs, I would probably say that everyone would know that breathing is probably quite important to life. And I put it there just in case you are worried that it's essential for life. Can anyone tell me of any illnesses or diseases that they know of? So remember we spoke about that independence-dependence continuum? Can anyone tell me where there is an illness that might affect someone's breathing, their respirations, but they're still healthy, but they do have something that they're not going to be fully dependent? So asthma is one, that's probably your quite common one, good. Croup, COPD, great one. So that's a really good one because COPD, you'll find that when you do the OBS for patients, with someone with COPD, their SATs are never going to be in the normal range. But just because they're sat at 89, that might be normal for them. So that's really good when we're learning about our patient and changing different things based on them. Good. Cystic fibrosis, another one. So good. So remembering, just because we're kind of tackling these things and we know, well, I don't have asthma, I've never smoked, I've never done this, that doesn't mean that we can't still be healthy because we've got chronic asthma or because we've had COPD. So eating and drinking. Now, this probably goes without saying as well, just like breathing, we probably kind of need to eat and drink. The most important there for me is that bottom one, is risk of malnutrition. It's really common, especially when we look at someone who is maybe a little bit huskier, like myself, and husky is the word I'm going for, not fat. You could probably look at me and go, well, he's clearly not malnourished. Like, he's got a lot of meat on his bones. He's not malnourished. That doesn't mean I'm eating healthy. I could be eating Maccas for breakfast, lunch, and dinner. I could be eating really poor, calorie-high, dense with calories, but no nutritional value. So just because you look at someone doesn't necessarily mean that they're malnourished or they're really well-nourished. You could look at someone really skinny and go, clearly they need a steak. But they actually might eat really healthy. I don't know why I'm using steak and Maccas, I'm a vegetarian. As an aside, I put on all this weight when I became a vegetarian, who knew? You can always get chips at a restaurant, and that's what did it. Another one here as well is cultural and religious preferences. Now, when we're talking about eating and drinking, I'm also going to cover under that banner about taking oral medications. I had a patient that came into me, and they were in quite a lot of pain, and I offered some oral medication. But they were on a month fast, and I offered some oral Panadol, and he said, "I'm really sorry, I can't take that because I'm fasting at the moment." And I was like, well, I don't know what to do for you then, because all the medication I can give you without you seeing a doctor is going to be oral. He's the only 14-year-old that has ever voluntarily had a suppository. He was like, well, I can't have an oral Panadol, but I'll quite happily take a suppository off you. I said, that's fine, whatever works for you. So again, just because people might have cultural differences that are slightly different to our own, sometimes we might need to be a bit creative and wonder, okay, well, how can I look after you? How can I best care for you? If you took that patient who was on a fast within a hospital, the unfortunate thing with hospitals is they deliver their meals at very set times. So maybe I need to take that extra as a nurse and think, well, maybe what I can do is I can collect your food, I can store it, and then you can have that later on when the sun has gone down and you can have something to eat. So sometimes as nurses, we need to really think about not just that physical issue that the patients come in with, but that kind of social, cultural issue, which if you remember, was on the far end of one of those kind of worldly issues that affect our life. So if we have patients that can't, for whatever reason, take anything orally, they are unfortunately going to be malnourished if we don't look after them. There are various routes, so enteral and parenteral. For whatever reason, they've had some surgery. It could be max fac surgery, so they could have had dental surgery, some such as the jaw. I'm also thinking of some oncology patients. So sometimes if you're on high dose of radiation or chemotherapy, you can have something called mucositis. Now, chemotherapy naturally kills really quickly growing cells, and your mucous membrane, such as your mouth, grow really quickly, because obviously if you burnt yourself with a coffee and it took you weeks for those cells to grow back, you'd be in pain for ages. So what happens is it starts to kill and starts to slough off all the kind of the tongue and in the throat. So sometimes they might need to avoid the mouth as well. So throat cancers as well is another one that you might have to think about not giving them something oral. So as you can see here, the most common one is nasogastric tube. So that one literally goes through the nose down to the stomach. The jejustomy, so the jejustomy tube is very similar. It goes through the nose, but it goes into a very specific part of the GI tract, and that's normally done under X-ray because it has to go into a certain part. Over here, so we have PPN, so partial parental nutrition, and TPN, total parental nutrition. If I'm having a stoma created, I can't have anything go into my GI tract, so I'm going to have this put up. So the TPN will be something like a Hickman or a Portacath. The PPN, you can see it's going into an arm, so that would be more of a PIC, and a PIC basically is just a long-term cannula. So if you're needing something for a month, it will go in here, but it will normally sit a little bit just above the superior vena cava. And that's what they look like. The gastrostomy tube. So if we go back here, so you can see the gastrostomy tube is going directly into the stomach, but this one sits on outside the stomach as well. So sometimes people refer that to as a Mickey button. I have no idea. I'm assuming it's made by Mickey. I don't know. But you access that the same way that you would access an NG tube. You can put medications down there. You can withdraw gastric fluid from there. You can put them on 24-hour fluids, or you can just push medication in there as well. The Hickman line, so that one is the one that's directly going into the heart. You can still use it as feeds, but a lot of the time, that would be something that you would use for oncology patients. So you can just about see that you've got one line going in, but then it splits into two. And sometimes that they will have a dedicated feeding one, and the other one will be for bloods and medications. Sometimes they split into three. So elimination. This obviously can be quite uncomfortable to talk to people about, especially if you, okay, I'm not tarring everyone with the same brush. It was uncomfortable for me when I had to do it first as a student. And I was like, well, I don't talk to my friends about that. Like, how do I go from never done it to I'm going to ask, oh, how many times do you poo in a day? I did, however, have a student once who went to a pediatric patient and said, oh, have you opened your bowels? And the child said, oh, I don't know. So the student came out to me and said, they don't know if they've opened their bowels. And I said, well, what do you mean they don't know? Like, it's pretty obvious if you have. And I said, do you think it might be that the child doesn't know? I think the child was maybe 9. Do you think they don't know what opening your bowels means? Oh, that might be it. Make sure you use the terminology that best meets your patient's needs. Unfortunately, the student went into a 9-year-old and said, have you had a shit today? That didn't go down well to the mum who was sat in the room as well. But do make sure that you are, when you're phrasing your questions, because it can be quite easy to go like a robot and go through all your tick sheets, but try and think, how can I actually make this less uncomfortable for me, and how can I make sure that I get my point across as well? Urine test, you will have the pleasure of doing these in your labs. Now, this is one thing that you can test your own urine should you wish. You don't have to, you don't have to collect the sample in front of anyone, but we will have lots of different samples that we have pre-prepared. But if you would like to see if you've got, cystitis or anything, then you can merrily go away and test your own urine. This is probably, as a student, this is probably going to be one of those things that will start to become really routine for you. Because unfortunately, not so much in an aged care facility, but once you hit the acute area, you are going to be given, until you earn your stripes, until they know you, you are going to be doing a lot of grunt work. It's going to be, oh, can you dip this urine? Can you go and empty this pan? Can you go and get a bottle for Mr. Jones? So it's going to be all the lovely stuff that's never shown on ER. That's the stuff that you're going to be doing. So you will get very good at this one. So again, make sure you pay attention in your labs, because this is going to be probably your bread and butter for a week or two when you get into 2 out of 3. Washing and dressing. Who has washed and dressed someone other than themselves? And I'm not including babies here. How comfortable are you in having to do your very first shower with someone? This, again, is also going to be something that is going to be your bread and butter when it comes to your aged care facility. So if you know that this is going to be something really awkward, this is something that you're going to have to reflect on over the next 4 weeks, because you can be guaranteed that you're going to be doing a number of showers on old men and old women and bits that you may have not seen in that position before. So please make sure you reflect and go, how am I going to cope with this? Now, not just showering someone, but how do you stop yourself from pulling a face? Now, that might seem like a really simple question, but I've had to clean off people that have been in a C collar. So when you see them on all the accident shows and they put them in a hard collar so they can't move their neck. If you can't move your neck and you need to go to the toilet, but you're being rushed from a car accident, guess what? They are not going to take you to the bathroom because you need to open your bowels. So what happens is, by the time the ambulance bring them to us in ED, they might have soiled themselves and be covered from head to foot in feces. And then the ambulance put them on the bed and go, bye, and off they go to their next dramatic scene. I've had to, with I think 5 people, had to clean, and this poor boy, and I could only feel for him. He was 16, he was on the verge of going into adult ED, but it was busy on that day, and we had to clean him fully because he'd soiled himself in the ambulance, and the ambulance quite happily just dropped him off and left. It was not nice. But the last thing you can do is, this poor person on the bed, they've completely soiled themselves. The last thing you want to do is go, oh, okay, well, I'm going to come in and do this. If you can just stay still, he's feeling bad enough as it is, without me grimacing and pulling a face. So try and think, not just how am I going to get through this, but how am I going to get through this and make it comfortable for my patient as well? Because if it's awkward for you, you can be very sure that it's going to be awkward for them as well. So please make sure that every little thing you do, especially in an aged care facility, these people may not have anyone to come to see them for days. The only interaction may be you. And if you put them off because you make a funny face, that's it. They're not going to talk to you, and that might be their only interaction for a couple of days. So please make sure that you make it really, all these awkward things that you might be feeling really awkward doing, try and make it really nice for your patient. I asked my wife, obviously because I've never had to clean an adult. I've never had to do a bed bath. I said to her, what happens if you do a bed bath or a shower and the gentleman enjoys it a little bit too much. And she said, well, if that's quite obvious, and that's all I'm going to say, is you sit them down on the shower chair and you say, I'm just going to go and I'll be back in 5 minutes. But if you think that you're in an awkward position, please make sure that there is lots of RNs, there is other people around to support you, because I know that when it comes to showering, they will often leave you on your own to do that shower. So please make sure if you're ever uncomfortable, you're going to need to do them, but try and think of your safety and your comfort as well. Thermoregulation, can anyone think of any, I'm not going to really use the word disease, but illness. Anyone think of any conditions, that's probably a better word, that thermoregulation might be an issue? In ICU, and to an extent also for operating theatres, is sometimes because of the things that we need to do and because of the access we need to patients, sometimes they're stripped down and only little bits are covering them. A lot of ICUs and hospitals are quite cold, so that can be something that can affect someone's thermoregulation. So it might be something that someone comes in with, so an illness or a disease that someone comes in with. I know I've been banging on about PEDS a lot, but that's quite a common one that people attend because their child has a fever. If you have someone, and this doesn't have to be a child, that could be your partner, your mum, whoever you're living with, whatever, they've got a fever of 38, what should we be doing straight away? What should we be doing for that person? So if someone's got a temperature, now it doesn't have to be in an aged care facility, a hospital, PEDS, whatever. So the answers we had, give them a blanket. Now, possibly, the reason I say possibly is because sometimes, has anyone had a fever, but they felt really cold, and the first thing we want to do is go to bed and put a big doona on. Now that's obviously going to make it worse. So sometimes we might need to compromise and say, well, why don't I change that doona and just give you a light sheet? So it might be that I don't want a blanket, as in I don't want a thick doona, but I might just give them a light sheet to make them feel comfortable, but I don't want to raise their temperature anymore. A cold face washer to the forehead. That's very kind of old school nurse movies there, kind of like the nurse comes in and pats the forehead. I like the vision of that one. I kind of half like that. Now, it used to be that we would put a cold compress on someone's head, we would put a fan on them, or we would give them a tepid sponge bath to cool them down. The problem is with all of those things, especially if I go for just the fan analogy, you put a fan on someone that is really hot, what's going to happen is you're going to cool their skin down, their brain's going to think, oh, bloody hell, I'm cold, and it's going to raise your temperature more. The same as if you do a kind of cold compress a bit too much. Like a slight cold compress, but not out of the freezer, which I've seen before, because that will cool them down too quickly, and then it will actually raise their temperature. Panadol. The no Panadol one, that gets my vote. Now, you've got to remember that temperature is just a symptom of something. A temperature is not an illness in itself. So a temperature on its own, I've had people come in and they go, oh, my little Johnny's got a temperature of 38.4. Oh, well, where is little Johnny? Oh, he's in the playroom. Well, I think he's fine. But if they're well in themselves, leave them, because 9 out of 10, I may have made that stat up there, 9 out of 10 fevers are normally caused by a virus. What do we do for a virus? Let it run its course. The more Panadol you give, and when you lower the temperature, and Panadol will lower someone's temperature, but it means that the body can't fight off that virus, and it means that you're extending the period that someone has a virus. If you're at home and someone's temperature is that high that they're delirious, climbing the walls, then yeah, please give them a Panadol. But if they're quite happy watching Netflix, just leave them alone. Temperature regulation. Now, I'm going to show you something. I'm not going to pretend to understand this in great detail. I'm not a scientist. You will next trimester meet Matt Barton. He's the science guy, and I'm going to throw him under the bus. Anything that you don't understand, he's the person. There you go. I'm going to give you a heads up, okay, for anyone listening at home. If I ever say in a lecture, I don't really understand that, it's probably not going to be in your exam. Mobility. Now, this is something you're going to be doing in your labs, that you're going to be learning for things to assist people with their mobility. Try and think of all those people. So this one here, you're going to be teaching each other to use a wheelie walker. But what we are doing is that just because we're teaching these and you see them in lots of pictures, you know, with someone a little bit old, I have seen lots of children, lots of teenagers, adolescents use things like wheelie walkers or other mobility aids. So just because you're learning them in one context, you can use them in quite a lot of contexts. I'm going to show you one thing here. So DVT. So you're going to be also learning how to put TEDs on someone. Now, DVT is normally something in older people. Can anyone tell me why they think that might be? I'm not going to tell you if you're right or wrong, but why do we think that DVT is more of an older person thing? Because they don't move as much. So weaker vascular system, their heart's a little bit weaker. And also, not that this is an older person thing, but long-haul flights is your classic reason that you will get a DVT. Work and play. Now, for a lot of you, I'm assuming that work and play probably wouldn't be an activity of daily living that is all engrossing within your life. Yes, you're at university, but being a registered nurse and working full-time, that probably seems like a long way away. You're going to be second year soon, just going to say. That probably seems like a long way. Next year, the end of next year, you're going to be qualified. That's a bit scary. But for a lot of the people, especially in your aged care facility, they might have been retired for ages. Now, just try and put yourself in the mindset. You are here at university to try and learn something, to work, be productive, to have a purpose in your life. I do not know personally how I'm going to be able to cope when I am retired and I have nothing to do. I mean, I love my family, but a 2-week holiday, I'm chomping at the bit to come back to work because I just feel like I'm not doing anything productive. Now, how then do we think, if we're in an aged care facility, these people may have been retired for, 20 years. They don't really do much. They might not have a lot of family come in. How do we engage them in work and play? What kind of things do we think? We might have known some people in an aged care facility. We might have relatives. What do they do? What do we think we can be part of? Because I think a lot of the time we put all these things on like we're the ones that know exactly what everyone likes. But simply just asking them. You as a student are going to be in such a great position that nurses are they're so busy, especially in aged care facilities. You might have 2 nurses looking after the whole facility because it's mainly ENs that are doing the work. You have a great responsibility, an opportunity to be able to take that time to talk to people and find out what they would like to do. Is there anything you would like me to do for you? You are going to be going into an aged care facility in 4 weeks-ish, 4.5 weeks. What are you going to do that is going to help people engage in work and play? Is there other services available to them? So it doesn't have to be within that facility. It could be something that you can send them off to. Other things that are really important as well is get to know the routine of your facility, because it could be that you could just simply involve your residents in things that happen in the facility. So it could be, there's going to be gardens to maintain. Yeah, they're going to probably employ gardeners, but is there anything that you can get them involved in? Simple weeding or pruning or watering stuff. So it doesn't have to be out of the ordinary. It could be stuff that is already happening. It could be simply, well, do you want to help out giving out lunches? Just because someone's in an aged care facility doesn't mean that they want to be waited on hand and foot and they're completely useless. So it might be really simple things. And it could be, that I've seen students in one facility did like a Taco Tuesday or something because they were because remember when you're there, you have this extra time that you can invest in the place. So if you think of something that might be really good for the facility, have a chat with your nurse and say, hey, do you mind if we do something? If you don't have the confidence to, that's absolutely fine. But I know that that's happened quite well in other facilities. This is probably another one of those uncomfortable things, especially when we're going into an aged care facility and we're thinking, oh my God, people are going to tell me about their sex lives. That could be what they're going to tell you about. But as you can see there, when Logan and Tierney came up with the expressing sexuality as one of the ADLs, we're not just talking about people's sexuality, but it's also about how we see ourselves in the world, how we relate, how we kind of see ourselves within our body. I will, however, say that when I was a student and I was looking for part-time work, I went onto the high street and I kind of gave my CVs out because we were old school then and that's what you did. And I went into one shop and they offered me an interview. Now, the shop was called Ann Summers. Now, if anyone knows Ann Summers, it's basically like your high street version of your adult shop. And in the interview, they said to me, most of our customers, there's like walls of vibrators and bras and all these things that, as a 16-year-old, I was like, oh, I don't know if I want to work here. But at my interview, they said, most of our customers are over 60. How are you going to deal with helping someone try on a bra? And in my interview, I said, I think maybe I'm in the wrong place. Thank you very much for your time. And I left. So whilst expressing sexuality doesn't necessarily just mean your sex life, that could be. Now, for me, that's going to be a very awkward conversation with an 80-year-old. So again, might reflect on that one and think, well, what kind of responses am I going to have in my pocket as soon as someone mentions that to me? But it is going to also be, like I said, it's going to be how you perceive yourself. So what kind of, gender role do you think you have? You've got a very old school male patient who is that kind of man's man, next to, buddied up with in a same room, someone who is a male patient who is very feminine. So just because, it's very easy to say, well, that male in bed 3 and the male in bed 4, I'm going to look after them exactly the same. But every individual needs to have the appropriate nursing assessment so you can look after your patients quite individually. I'm not going to mention too much about the bottom one there, but sometimes, and this is more for a speciality placement. So if you are on, obviously, if you're in a clinic looking after sexual diseases, or you're a sexual clinic, you're obviously going to be involved in these conversations a little bit more. If you're looking after, I've had to have quite awkward conversations with teenagers, especially when they come into ED and they complain of abdo pain. The first thing we're going to do is say, we're going to do a urine test and check if you're pregnant. We obviously wait till the parents have left and then say, this is what we're going to do, just to make sure. When the teenager bursts out crying, and you think, I don't think we need to do that. But now I need to tell the mum. And then you're all of a sudden in this position that you then have to, and it turns out it wasn't actually the pregnancy, it was something completely different. I think she had a UTI, but I've outed her that now she's got a baby. So we might find ourselves in very awkward positions and talking about very strange things that are completely unrelated to why the patient has come into us. So again, make sure you reflect on how you are going to deal with these different situations to make it much easier on yourself. So sleeping. Unfortunately, through lots of research, teenagers need a lot more sleep. So my 10-year-old, soon to be 11-year-old, when he doesn't wake up till 12 midday, unfortunately, I have to let him, and because that's going to improve his cognitive ability, I'm quite happy to leave him asleep till 3 because his cognitive ability is not great. The one thing I'm going to mention with this one, circadian rhythms. Now, there's lots of different things that go into circadian rhythms. The one thing I'm going to mention is a part of that rhythm is light and dark. So if we think purely from a point of, well, when it's dark at night, that's when I start to feel tired. And when it's light in the morning, that's when I wake up and I feel a bit energized. You'll see that when you go into hospitals, especially if you have to do a night shift, which is probably unlikely, a lot of the hospitals in this T room, they will have their lights set to circadian rhythms. I don't exactly know how you set a light to a circadian rhythm, but that's what they do. Because apparently when you're on a night shift, having circadian lights will keep you awake and motivated during the night. I don't know how that works. But have a look at circadian rhythms and how that can possibly, because remember, when we're looking after patients, they're in a completely different environment. They haven't seen the sun for God knows how long. Their sleep pattern is going to be completely disturbed, which is then going to affect how they work and how they interact during the day. So try and think about how you can assist someone have a normal sleep pattern, because that's going to have a massive impact on all of the different things they do during the day. I really want to do modeling for all these medical companies, because if you go onto the internet, there's so many kind of different weird things, and the model's just kind of, like it's just an everyday kind of activity. Oh, here's me with a mask. I've had a sleep apnea or a CPAP. I would probably say that I would be a better model for this one, because it's normally someone who is a bit huskier, who might need CPAP at night. Does anyone know what CPAP stands for? Continuous positive airway pressure. Now, don't worry, you're not going to have to learn too much about that, but when we do our respiratory lecture, I will mention that a little bit, because whilst you might not be using CPAP machines, if you're in an emergency, sometimes you'll be putting CPAP valves on your bag, and there's a good reason for that, but we'll cover that later. So death and dying. Now, unfortunately for me, we do have a lecture on death and dying. I find this, out of all of the lectures that I ever teach, the worst one for me, because I, even now, after doing this for God knows how many years, find this a really, really difficult subject to really actively engage in without making it really overly depressing. So without trying to make it overly depressing, it is something that, you know, everyone's going to go through. And especially when you get to your aged care facility, those are probably going to be residents or patients that have probably thought about that a lot more. And they might be quite happy to talk about that kind of stuff, and you need to be prepared for that. Because if you're not, and if you're uncomfortable, they're going to know that you're uncomfortable, and they're then going to start feeling sorry that they've made you uncomfortable. So be prepared that you might be involved in some conversations. We will also be talking about palliative care as well, so I'm not going to depress you about that right at the moment. I'm going to leave you with a story for death and dying. When I did, because I trained as a paediatric nurse in England, we had lots of different placements, and one was an adult placement. And it started off in an adult private hospital, and private hospitals in England aren't like here. Like if you've got private health insurance in England, you're a bit of a snob. So we were looking after these very, very well-to-do people, and someone was sent home, and we were asked to go and visit them because they had to, I think they had some wounds that they needed dressing. This patient was palliative. I can't remember what leukemia they had, but they were palliative. They'd been palliative for a long time. When we walked into their house, in the corner of their room was a coffin, which put me off straight away. They had a coffin in their room. Now, that wasn't the weird thing. The weird thing was, it was a lovely white coffin, and they had all these scribbles on. And the woman said, you know, like when you break an arm and you get people to sign your cast? The woman said, everyone that looks after me or everyone that I love, I get them to sign my coffin. And half of it was, that's really cute, and half of it was like, oh my God, you're going to ask me to sign a coffin. But she had been so comfortable with it, and she had been to the point where she had come to terms with it. She had thought about, okay, well, this is going to be an eventual thing. How am I going to make it something about me? And she went to the bold move of buying a coffin before she's dead. I mean, she wouldn't be able to buy it afterwards, but then putting it in her living room and getting people to sign it. So clearly there is going to be people that are very, very comfortable with this topic. And for me, it was really, really confronting. So again, think about how you're going to deal with that if you have to start conversations around death and dying. I did, yes. I tried, but I felt really bad because I'd only met her a few times. I tried to write the smallest signature as possible because I didn't want, like someone at the funeral was going to be like, well, who's Danny? Why is he not here? So I tried to write it as small as possible. No one phoned me after the funeral.